So we're going to cover AV blocks. We have first degree block, we have second degree, we have a type 1 and a type 2, and then we have a third degree block. So what you need to realize is an AV block, what's happening there, the impulses are being blocked from the atria to the ventricle. Now, the degree of blocks are going to depend, so that's why we have all these different degrees of blockages, and we're going to talk about each one. I'm going to give you some examples. The first one I always like to talk about is a first degree AV block. So I know it's labeled as a block, but it's not really a block, because what happens is all the impulses get through, it's just slower than what it should be. That's what's going on here. So all the impulses do reach it, it's just slower than what it should be. So that being said, your PR interval is longer than what it should be. So when you're doing the 5-step analysis on a first degree block, the first thing, of course, we look for is your rate. Your rate usually is 60 to 100 beats per minute. The underlying rhythm is regular. And remember, we look at that, we look at our R to Rs, and we see that our R to Rs, they're regular. And then what we do is we look at our P waves. And you do have a P wave before every QRS, and your P waves are all similar in appearance. So when we look right here, you see here's the P wave, here's the P wave, here's the P wave, here's the P wave, and here's the P wave. Okay? Then remember, we're going to look at our PR interval. What you're going to notice about your PR interval, remember this is your PR interval, okay, right here, is that your PR interval is just greater than what it should be. So it is greater than 0.20 seconds, and it's consistently greater than 0.20 seconds. So that's what you have in a first degree block, is you have a prolonged PR interval. And that makes sense, guys, because remember, it's taking longer from the electrical impulses from the atria to get to the ventricles. So this PR interval, remember that tells you how long it takes impulses to get from the atria to the ventricles. So it is going to be prolonged. And what I mean by consistently, let's say this one is, or we'll start with this one right here, because this is the first one that we can clearly make out here. When you look at this PR interval, let's say this PR interval is, we're looking at it, and it is 0.28 is what we're saying this is. Well, then we look at this one should be 0.28. And then this PR interval should be 0.28, and then this one will be 0.28, and then this one will be 0.28. It's consistently the same. So all the impulses go through, it just takes longer for them to get there. So that's the thing with first degree block. Now, realize in first degree block, we consider it kind of a watch rhythm. You want to make sure and notify the doctor if that PR interval is getting progressively longer. And the reason that is because it could potentially turn into a second degree block. And we also look at their medications. If they have this block because of medications, well, then what we do then is we want to make sure that we adjust the medications or we hold the medications, whatever it could be that is causing it. Things that are very prone to cause a first degree block are your beta blockers, your calcium channel blockers, and also DIG. And then again, it just could occur. Some people it just happens. There's not really a reason for it. Or they could have underlying cardiac disease, such as coronary artery disease, or they could have myocardial infarction, or they could have just had myocarditis. So there's lots of things that can cause a first degree block, but when you are trying to analyze it using your 5-step method, like we can do that on this one right here. So you count the number of the first thing, let's look at our rate, you count the number of complete QRS complexes. So we got 1, 2, 3, 4, 5, 6. We have 6. So then what we do is 6 times 10, our rate is 60. The next thing we want to look at is we want to look and see if it's regular. Well, I'm looking at my R to R, and what I see is that, yes, it is regular. So then you're going to look at your P waves. What you notice is I do have a P wave before every QRS. See, here's a P wave, here's your QRS. Here's a P wave, here's your QRS. P wave, QRS, P wave, QRS. So, and they all are similar in appearance. And then remember, the fourth step is you want to look at that PR interval. So what kind of catches your eye, or what should catch your eye with this PR interval, is that it's longer than what it should be. And so when you look at each one of these PR intervals, and this one is clearly mapped out for you right here, it is greater than 5 small boxes, or it's greater than 0.20 seconds. So that's the key feature in a first degree block. When you look at your QRS complexes, they are within defined limits, so those are fine. As I've spoken with you earlier, again, first degree block, it could be completely normal. I listed some things here that could potentially cause a first degree block, but again, we're not going to treat it unless it's related to a medication, okay, and then we will treat it. So when we look at second degree blocks, you might know of second degree type 1 block. It's also called a Winkie block. So if that's your terminology, that's something that you want to get in your brain for testing purposes. It's second degree type 1. Okay, but essentially what's happening here is the impulses, they just take a little longer to conduct through the AV node until eventually one impulse is completely blocked. So not all the impulses reach the ventricles, and it results in a dropped beat or a dropped QRS complex, because remember, the QRS complex tells us what's going on in the ventricles. Some causes of a second degree type 1, it could be that the person has had an MI, or it could be because they have had recent cardiac surgery, or an electrolyte imbalance. Any of those things can cause a second degree type 1. Again, your patient is usually asymptomatic in a second degree type 1. You're not necessarily going to do anything unless it's related to medications, or if it's something along that nature then. Okay. So here's a great example of a second degree type 1. Let's do our 5-step analysis here, because I always like to go over those. The first thing you're going to look at, your rate is going to vary. I can't give you a rate, guys, and the reason I can't is because it depends on the number of dropped QRS complexes as far as what their overall ventricular rate's going to be. So the rate's going to vary when you're looking at this type of block. Your rhythm is going to be irregular, and the reason it's going to be irregular is because you're dropping beats right here. So if you look at this picture, you can see, just going through and looking, is that I've dropped a beat right here. So what this tells you when you drop a QRS complex is that the impulse was blocked right here. Okay. So P waves, you do have a P wave before every QRS complex. However, there is not a QRS complex after every P wave. So I'm going to explain that to you just in one moment to try and help you understand that. And then the other key feature of a second degree type 1 block is that your PR interval gets gradually longer with each successive beat, until finally the P wave, it fails to conduct to the ventricles. And when that happens, guys, that's when you're going to have that dropped QRS. So your QRS complexes, when you have them, they are normal, and they are within defined limits. So that's your 5-step method for your second degree. So let's practice on this one right here. My rate right here, remember, is, let's see, we got 1, 2, 3, 4, 5. So my rate is 60. Then I look and see if it's regular. Remember, you look to your R to R's to see if you're regular, and what you see is it's not regular, because you should have an R right here, a QRS complex, and you don't. So that makes this irregular. And then you look at P waves. Do I have a P before every QRS? There's a P. There's a P. There's a P. But wait, okay, so I don't have a QRS there. Here's a P. Here's a P. There's a P. So yes, I do have a P before every QRS when I have a QRS complex. And the P's that I do have, they are similar in appearance. However, what I notice is I have some extra P's in here. You see this extra P right here? Okay? That's because, for whatever reason, it dropped right there. So you will have some extra P's. And then you look at your QRS complex. So the QRS complexes, they are within defined limits. I'm sorry, guys, I forgot the PR interval. That's the most significant thing here. Okay? So when you're looking at your PR interval, let's look at it real quick. Okay, we can't really use this one because we don't have the star or the P, so you always want to go here when you're looking at PR interval for the first one on the strip that you can see. So here's my P, and here's my QRS, here's my PR interval. Okay, so I do have a PR interval. Let's compare it with the other ones. So then I go to the next PR interval. Well, wait a minute, look, it's longer than what it should be. And I have it clearly marked out for you. This PR interval is 0.34. This one is 0.52. So my PR interval is getting longer. And then here's my P. Sorry, guys. Here's my P. But look, I dropped a beat, so I don't have a QRS complex. So I can't measure a PR interval right here. So what happens is you go back here and you start over. So here's my P. Here's my PR interval right here. And then look at the next PR interval. Do you see how it's gradually getting longer and longer, and then it drops a beat? That is your key feature of your second degree type 1. With these blocks right here, the best way to tell the difference between your blocks is you go to that PR interval. Okay, guys? So I told you first degree, you have a PR interval that is just prolonged. The second degree type 1, I like to refer to it as it's your going, going, gone, because you see how it, let me find my mouse here. Here you go. You see how it gets progressively longer. It drops a beat, and then the pattern starts over again. That's your key feature in your second degree type 1. Okay. So here's another example. Let's look at this one and see if we can do the 5-step method on this one. So the first thing we look at is our rate. So your rate right here is what, 60? Okay, so then what you want to look at is you want to look at your rhythm. Is this regular or irregular? Well, just by looking at it and looking at your R to R's, what you see is they're not regular. It's irregular because look right here. You should have a QRS here and you don't have it. So that kind of lets you know that something's not quite right here. So then you look at your P waves. What you'll notice is I do have P waves. My P waves are similar in appearance, and I do have a P wave before every QRS. Let me point them out for you. Here's a P, here's a P, here's a P. Okay. There's a P, there's a P, there's a P, there's a P. So yes, I do have a P before every QRS complex. Now let's go and look at that PR interval. Okay, so start with the first complete PR interval you have, and it's right here. Okay, so we're looking at this PR interval right here, and then I want you to compare it with the other PR intervals. So here's a PR interval right here. Now let's look at this one. Here, what do you notice about this PR interval? Compare it to this one. See how this one is getting longer? Okay, well let's check out the next PR interval. I have a P right here, but you see how I have a dropped beat, so I'm missing a QRS. So I can't measure a PR interval right here. So what happens is your pattern starts over after you miss that, or after it drops that beat, then your pattern starts over. And what I mean by that, look at this PR interval. Okay? So here's your PR interval. Then look at the next PR interval. You see how it progressively gets longer and longer, and then it drops a beat, and then the pattern starts over. That is your second degree type 1, guys. Again, you're not really going to do anything if your patient is stable. The only time they become unstable with this is for some reason those dropped beats, for example, let's say you see how it's dropping a beat right here. Well, if it dropped more frequently, let's say it was dropping every other beat, and that would make the ventricular output, let's say, would make it 60. Well, then your patient's going to have some signs and symptoms, and the signs and symptoms they're going to have, of course, are decreased cardiac output. So one thing you want to make sure you do is you, of course, want to give them oxygen because they don't have enough circulating. And then what you do is medication-wise, we try and give them atropine, because what atropine is going to do, it is going to increase their overall rate, and that's what we want. Sometimes what we have to do is we do have to put them on an external pacemaker. So we put them on an external pacemaker if their rate is so low that they are very symptomatic, and we put them on there until we figure out what caused this, what exactly led to them having this very symptomatic low rate that they have going on. So if it's medications, then they're going to be on the external pacemaker until the medications have wore off, until we've done the adjustments. If it's something just wrong with the anatomy of the heart, or there's a blockage somewhere else, then what we might have to do is we might have to do some cardiac interventions to go in there and clean those out, or whatever we need to do to fix this block. Sometimes we'll have to put an internal pacemaker on them, and an internal pacemaker, remember, all it's going to do is going to regulate their rate. So those are all options that we have for a second degree type 1. So let's move on and go to second degree type 2. I always like to use this slide because everybody's like, is it upside down? No. Remember how I told you there's different leads? This is just a different lead than what you're normally used to. And so that's why your QRS complexes are negatively deflected, but you read it exactly the same. So we're going to do the 5-step method right here. Your rate is going to vary. I can't tell you what the rate will be because it just kind of depends. Your rhythm, it could be regular or it could be irregular. Either one. P waves, you do have a P wave before every QRS complex, but they will be positively deflected. Then what you want to do is you want to look at your PR interval, because remember I told you when you go to blocks, the key features or the key differences are in their PR intervals. So what you're going to see in a second degree type 2 block is your PR intervals. They could be normal or abnormal. However, they will be consistent when the impulses are conducted to the ventricles. Okay, and I'm going to explain that in just one moment. Your QRS complexes, they are normal, so they're within defined limits. So let's look right here and do the 5-step. Well, your rate is 30. This person probably isn't doing so well. Your rhythm is irregular, as you can tell. You're missing a lot of beats right here. You look at to see if you have a P before every QRS complex, and you do. You see that you have an extra P right here. And so then what you want to look at is you look at your PR intervals. So you look at your PR interval. Okay, and what you see is that your PR interval is consistently the same. So if this one is 5 boxes, then this one is 5 boxes, and this one is 5 boxes. Okay, these 5 little red boxes. So it is consistently the same. The only issue here is I have more P's than I should. Okay. Then you look at your QRS complexes. Your QRS complexes, they are within defined limits. So again, the main feature in a second degree type 2 block is you're looking at these PR intervals, and your PR intervals, they could be normal or they could be abnormal, but they're going to be consistent whatever they may be. Meaning if this first one is 0.25 seconds, then the second one will be 0.25, and then this one will be 0.25. They're consistently going to be the same. The reason for this type of block, or I should say this type of block, occurs below the bundle of His. So those impulses are just blocked very randomly, and so typically that's why the ventricular rhythm is very irregular. Now we do worry about a second degree type 2 block, and the reason that is because a lot of times they progress to a third degree block, or something we call a complete heart block. Okay, so frequently it will progress to that. Some causes of a second degree type 2 block, it could be because they've had an MI, or they have some type of heart disease. It could be because they have myocarditis, or it could even be due to dig toxicity, guys. That's why it's so important that you make sure that you know your meds, and you know what you're supposed to do before you give your meds. So the first thing you want to do, of course, we always verify that person, so we're going to do EKG and make sure that they actually are in a second degree type 2, and then we assess our patients and look for those signs and symptoms. Remember, the signs and symptoms they have are going to be dependent on the number of overall dropped beats, and then that leads to what your ventricular rate is. Okay. Remember, this person is at an increased risk for decreased cardiac output. Okay, so as their rate starts dropping, realize they're going to become symptomatic. So currently what we do for a second degree type 2 is we give them oxygen because we know that they don't have enough circulating oxygen. A lot of times we still try atropine, but it's usually ineffective, and the reason it is because of the location of the block. Atropine does not tend to work too well on that. And then what we will do is we will put them on an external pacer. We also call it pacing. That's just a terminology you'll hear in the clinical setting. But essentially, what we're doing is we are trying to regulate their heart rate. Okay. Now, if this is not due to medications or something underlying as far as some type of procedure that we've done, then what we will have to do is we will have to have, or the patient will have to have a permanent pacemaker. That is what long-term management is for recurrent second-degree type 2. Third-degree block. Guys, third-degree blocks are really easy to pick out because what you have to realize in a third-degree block is there is no communication between the atria and the ventricles. The atria is doing its thing, the ventricles are doing its thing, and they're not talking. Well, the reason that is a problem, remember, to have, for our heart to work like it should, our atria talks to our ventricles, and then our ventricle puts out all the blood to our body. That's not happening here. And so that's a huge issue. A third-degree block is also called a complete heart block. And so when you suspect someone's having a third-degree heart block, realize that we always want to do EKG, but what's going to happen is they are going to become very pale, very sweaty. They're going to become very confused. They become hypotensive. They're going to have periods of where they're going in and out of consciousness. They're going to have the signs and symptoms of congestive heart failure because their heart is failing. It's not working as it should. What happens in third-degree heart block is it leads to cardiac arrest if you don't catch it, because our heart has to communicate. The ventricles of our heart, they have to put the blood out, and the atria has to tell them what to do. So it is essential in a third-degree heart block that you recognize it and you act quickly. When you're doing the 5-step method on a third-degree heart block, the first thing you look at is the rate. But what you have to, or your key principle you have to keep in mind when you are looking at these strips and you were thinking a third-degree heart block, remember there's no communication. So the atria is doing its own thing and the ventricles are doing their own thing. And so that's what you have to realize here when you're looking at this, okay? Your rhythm, it could be regular or it could be irregular. Your P waves, you do have P waves, but there's no relationship to the QRS complexes. And you can even have some P waves that are buried in the QRS complexes or even the T waves. You can't measure a PR interval because, remember, no electrical impulses are being conducted from the atria to the ventricles. And then your QRS complexes, they're either going to be less than or greater than what they should be. So that's the biggest thing you need to realize here, okay? So I always like to tell people a neat way to remember third-degree block. If your P and Q don't agree, then you have third degree, okay? So I'm going to show you some examples of that. When we come up here and we look, let's do our 5-step method, okay? Well, the first thing is rate. All I can tell you right now is here's my 20, a rate of 20. And then you look at, is it regular or irregular? Well, just based off this appearance, it looks regular. Okay? I look for P waves. Yeah, I have P waves. You see, I have all the P waves marked. Okay, so there's lots of P waves there. But one thing you notice about your P waves is they're just there. We have lots of P waves. And then when you look at your PR interval, you can't measure it because there's nothing consistent about it at all. I have P's, I have QRS's, but there's no relationship. Nothing's coming after this P, and we know it should always be P, QRS, and there's nothing here. Okay? So let me show you this one because this is another great one right here. Okay? So remember, if your P's and Q's don't agree, then you have third degree. So our rate right here is 30. We look at it, and currently it looks regular. And then you look for your P's, and you see, yes, I have P's, I have P's, I have P's. But they're not in relationship to anything else. It doesn't mean anything. PR intervals, I can't measure a PR interval because, again, they're not talking. There's no communication going on. So what you have to do in someone's having a third degree block is, one, they need oxygen. But two, you've got to try and figure out what's causing it. If it's not medically induced, then the person is going to get a permanent pacemaker. Some things that can cause a third degree block, so again, severe DIG toxicity. It could have had an MI, or also even a severe electrolyte imbalance. So those are all things that you need to examine when you have someone in a third degree block. So I made this little chart for y'all to try and help you out when you're telling the difference, when you're looking at the differences between your PR intervals or your blocks. You want to go to your PR interval, guys, because that's where you're really going to be able to tell the difference between your different blocks. And so this chart, use this when you're going through and you're trying to figure out your blocks. And remember, it just takes practice